I was a commission member, and now I'm an officer in the Medical Society. I had the privilege of extensively meeting with physicians all over the Commonwealth. While the commission was meeting earlier this year, we went to forums throughout Massachusetts. We held meetings at every single nook and cranny across the Commonwealth. And I just want to summarize some of the things we heard the physicians say. They said one size does not fit all. The dose of anesthetic I would use for a 20-kilogram kid is very different than what I would use for a 100-kilogram man. It's not the same. The healthcare system in Massachusetts is too diverse to impose a single solution on everyone. Specialties are different. Practices throughout the state are very different. Patients are definitely different. The diversity of our healthcare system is one of our strengths, and my colleague said we must take this into account when we think about new payment models. Secondly, they also said that there's a serious problem with primary care in this Commonwealth. In my opinion, the deficit in primary care medicine is the rate-limiting step to optimal health care access. It is the rate-limiting step. Thirdly, they said that physicians need lots of financial support, and they need lots of help getting the expertise to make the transition, whether it's global payment or any other type of payment. For example, the expertise and capital needed to install electronic health records alone is huge. It's enormous. We get letters all the time at the Mass Medical Society about just the cost. You should know that 63% of practice providers in the Commonwealth are either onesie, twosie doctors. Some of them do work under the umbrella of larger institutions, but we have a large percentage of single docs and two doc practices within the Commonwealth, which really introduces a whole nother problem in terms of the overhead and covering the implementation of electronic medical records, just the costs alone. My colleague said that physicians and hospitals will have to organize themselves differently. This is not possible when we talk about accountable care organizations without some changes with law in terms of antitrust. And medical liability is like an infectious disease which fuels the cost escalation. The medical liability climate in the state encourages the practice of costly, wasteful defensive medicine. In our study, it showed that 83% of physicians practicing admit to, at one time or another, practicing defensive medicine. I was on call last night. I've been up for 24 hours. Okay, I covered the ICU. There's certain things that now I'm a little bit more savvy when it comes to cost. But, you know, thinking about how I practice medicine is constantly a barometer for what am I doing that's next to defensive medicine. I mean, what are the things that I do that are necessary, and what are the things that are, I think, going to help me in the future in case there's a lawsuit. I think those are really important things. I would urge Massachusetts, even in the midst of the Payment Reform Commission's recommendation, that we need to do the right thing. Don't ignore the elephant in the room, which is the practice of defensive medicine, which drives costs out of proportion. Physicians are not amnestic. They remember. Most of all, I hear my friends and colleagues say this one very thing: capitation, it's here again. So what do we do to convince all of my colleagues, physicians across the state, this is not capitation? And we've talked about the notion of introducing pay for performance and risk adjustment. It has to be done right, and it has to be done with the right infrastructure. As I've said at the commission, if A, therefore B. Some physicians can transition into this, some cannot. They don't have the support to do it. They ask, how will practices be protected against undue financial risk? How will physicians get enough resources to provide the right care? How will patients trust a system that strives for optimal care, not just maximalist care? We know that evidence-based medicine doesn't always call for the most care. It calls for the right care. Sometimes overtreatment is just as bad as undertreatment. Patients may not be used to this idea, and that's a whole cultural transition that we need to address. Finally, I think the commission did a stellar job of addressing the insurance risk versus performance risk, and I think there's a lot more work that we need to do in that venue. Because the commission's mandates, there are many things that we need to address as we go along. For example, the commission didn't spend very much time on the episode of care. We talked about the drivers of care in this state. Congestive heart failure, large, joint replacements. Joint replacements were the #1 procedures. $290 million attributed to joint replacements alone, and that doesn't include other orthopedic procedures. The state's own research proved that relatively small handful of conditions account for all the disproportion of healthcare spending. For example, Just 25 diagnosis groups accounted for more than $3 billion in hospital spending in 2007. The Commission didn't study this approach in much detail, but these are the large cost drivers of our systems, and if we have an opportunity, we need to address them. One place where legislation could start could be to establish several rapid test pilot projects around episode group payments like these. In a short period of time, we could learn a lot, what works and what doesn't. And in addition, it would also give practices in hospitals lots of experience with other, possibly other payment models, and would minimize the risk of negative disruptions. And I would mention here again, the workforce is a tenuous place in Massachusetts because we do have the primary care crisis, and even in our workforce study, we've shown that there are new areas in family practice that are really suffering as well. And like I said, that's a rate limiting step. Finally, I want to put an urgent plea that practicing physicians be named to the oversight authority. That's a must for payment reform. With full voting rights and full power to make policy. One thing we learned at the Commission is that the voice of the practicing physician is absolutely essential to developing a system that actually works. At the end of the day, physicians will be the ones expected to work in the new system. It only makes sense that we also design it. And as my colleague, Dr. Mata, has said, we have demonstrated that we can be active partners. We want to be collegial, and we want to be co-partners in changing the whole architecture and the landscape and cost control. Thank you.